Good evening, everyone, and welcome to the IMF first teleconference of the year. But first, before I begin, this is Susie Noes, I need to turn it over to Karen, who's going to give you some instructions.
During the Q&A portion, when we go into queue for Q&A, if you'll press star 1 to go into queue, and I'll open your lines for questions. Ms. Stacey Novus, you can go ahead.
Okay, so again, good evening and welcome to the IMF first teleconference of the year. Tonight's call is the Best of ASH 2013, What Myeloma Patients Need to Know. I have to tell you that this year's annual meeting of ASH was really an incredibly active one. And to give you an idea of just how active and busy we were, at the IMF Friday Night Satellite Symposium, we had over 1,000 participants, which was really amazing. It's the largest one ever. This symposium is for doctors, and they came from all over the world to be at this event. I don't blame them. We had a stellar faculty that was comprised of members of the International Myeloma Working Group, with Dr. Durie as the chair of the symposium, and joining him were Drs. Philippe Moreau, Jesus San Miguel, Antonio Palumbo, Shaji Kumar, and Vincent Raj Kumar. Needless to say, the room was packed, and everyone came to hear what the rock stars of myeloma had to say, and I have to tell you, it was a very lively and very informative symposium. So you're about to hear from Dr. Durie about that and all the other highlights from ASH. So before he gets started, I'd like to take a moment and thank the sponsors of tonight's teleconference, Celgene and Millennium, for their support of this program. I also want to remind you that our first patient and family seminar of the year will be held in Boca Raton, Florida, and that will be the weekend of February 28th and March 1st. So to register, you can either go online or call the IMF toll-free number, 800-452-2873. Now, as a reminder, you'll find a link to the slides that Dr. Durie will be using tonight by going to our website if you already haven't done so. And if you go under New and Noteworthy, which is on the front page of the web, there's a second bullet down. Just click on that, and that's where you'll find the slides. So now I suggest that you all just sit back, relax, and Dr. Durie, it's all yours.
Well, thank you so much, Susie, for that kind introduction. Just a few other practical points. I will be going through the slide deck, which you might have in the computer or maybe have printed out ahead. To identify the slides for everyone, I will be identifying by the title of the slide to make sure that everyone is looking at the correct slide. The next thing is that I realize that I am talking to people, some of whom know extremely well what ASH is and maybe have heard many of the results that I'm going to discuss this evening. And then maybe many of the others on this call are not even really sure what ASH exactly is. And so for each topic that I cover, I will discuss things in quite a bit of detail, but then at the end of each of 10 segments, I've divided this talk up into 10 segments, 10 of the top areas at ASH this year. As a last slide for each of those 10 segments, I'll have a takeaway point, a summary. And so if you maybe haven't fully understood all of the numbers and charts and things like that, there will be a takeaway point at the end of each segment. So hopefully that will be helpful for everyone. And so the Best of ASH 2013, the American Society of Hematology is the main blood cancer society in America, actually in the world, and this is where we expect to find the new and most important information about myeloma every year. And this year, as you can see on the cover slide, this was held in New Orleans in the early part of December. If you go to the first slide, which is headed ASH 2013, I show, well, how many abstracts were submitted for ASH this year. And so abstracts, what that means is a project which was submitted with the results for presentation at ASH. And those abstracts, those summaries can be presented orally, where the doctor will actually present the results to an audience, or in the form of a poster where the poster boards will put up in a room where it will be possible for the people attending ASH to go through and browse through a room full of posters and see and discuss the results from the posters. So those two formats are used to present the results. In general, the oral presentations are considered to be much more prestigious, and usually the major results would be presented as oral presentations, whereas those felt to be a little less important might be in the form of posters. And so on this slide, you will see over 800 abstracts, which is amazing for myeloma research. Of those, we had to select some that seemed more interesting and important, and so we selected 131, about 15% of those, which seemed to be more important. And you can see of those, 38 were particularly important, presented as oral presentations, and the other 93 in the form of posters. Now, you can see that for the oral presentations, most of those were new therapies, and so one has to admit that really when it gets right down to it, we're mostly interested in, well, what is new in terms of treatment, information about how to use some of the novel drugs that we have and what completely new drugs are coming down the pike. You can see 20% dealt with that. And then biology, that means understanding the background information about myeloma, the genetic testing, the growth studies, animal studies, understanding the background pattern of myeloma. And you can see that the posters predominantly cover this kind of background biology information, genetic information, prognostic factors, understanding more about the background of the disease. And relatively few new drugs would be presented in the form of a poster, 7%. So if you go to the next slide, I've made a list of the top 10 of what I call the hot topics for ASH 2013. And so you can see right away that these mostly focus on drug therapies, mostly on drug therapies which are FDA approved and commercially available. And so this is a big focus in myeloma right now. We are very, very fortunate in the field of myeloma that we have several important new drugs that have been approved by the FDA and are now available. And so, for example, we have the first novel agents, Thalidomide, Revlimid, and Velcade, and then more recently this past year, we had corphilson and Pomalidomide, and I'll be talking about all of these a little bit. And so basically, we have 5 very active novel drugs, and we are trying to figure out the best sequencing and combination of how to use these drugs. And so a lot of the focus at our meetings is to evaluate just that. You can see that items 1, 2, 3, 4, 5 are focused on that, how to best use these 5 novel agents. Item number 6 is the role of transplant, both autologous and allogeneic transplant from a matched family member donor usually. A big topic at this last ASH in December 2013 was the role of assessment of minimal residual disease. And I'm going to spend a little time talking about that. But basically, this is the first time that we've really focused on this a lot, and this is because our treatments are working better. Now, we're to the point where it looks like we've wiped out the myeloma or we're getting really close, and so we have what's called minimal residual disease, and it's become important to assess, is there minimal residual disease? Is it 0 or is there a little bit left? And so this very, very sensitive testing has become quite a hot topic. Then number 9, high-risk features. This is the way in which we would select maybe more intensive therapy for someone who might have abnormal chromosomes or features that we would consider to be a little bit more daunting, where we might need to be more aggressive with the treatment or maybe use some different combinations. And then number 10 is a little bit new, where we're starting to learn about, well, why do people actually get myeloma? What predisposes someone to get myeloma? Why would someone get myeloma and not some other kind of cancer, or maybe no cancer at all, which would be great? So those are the top 10 topics, and so I'm going to go through them one at a time and show you a few slides on each of those and then have a summary slide. And so if we go to the first topic, which is Revlimid and dexamethasone in the front line. Now, something quite important about this, it says frontline therapy for transplant ineligible patients. This was a plenary oral presentation. So this means that it was selected as one of the most important abstracts overall for all the different blood cancers that was presented at ASH this past year. And so it was considered to be a very important set of data, and the reason for that was several. Reasons are several. It's a very large study. If you look under the top red box, you can see that this was a trial called MM020. That's the number of the study. It was conducted in large part by the French group, the IFM, and they called it 0701. You'll see after that there were over 1,600 patients, so 1,623 patients in this trial, patients over the age of 65. So a very, very large study contributed to this trial. And they were treated in 3 different ways, A, B, and C. So a third of the patients, so about 500 patients, took Revlimid plus low-dose dex. That's the dexamethasone, the 1-day-a-week schedule. So Revlimid for 21 days, 1 week off, and then repeat dexamethasone 1 day a week. And they took it on an ongoing basis. And this was compared, Arm B, with where they stopped after 18 cycles, which would be 18 months, 4-week cycles, and versus Arm C, where they took melphalan, and thalidomide, the older drug like Revlimid, IMID, which we've used prior to Revlimid. And this is a 6-week cycle, and there were 12 cycles, so that was also 18 months. So 18 months versus ongoing. And the results were very clear-cut, which is why this was selected as a top abstract. The progression-free survival, which is basically the length of the remission, was substantially longer, 28% longer, with the Revlimid Dex on an ongoing basis versus the other 2 arms. So taking the Rev Dex ongoing was superior to stopping after 18 months. And this led also to improvement in the survival of the patients, and about a quarter, 22%, fewer patients died of the myeloma versus the other arms. And so a very, very important result. A concern has been raised that maybe Revlimid would increase the chance of developing a second cancer, and this is something that we've discussed in the past, but actually in this study, very low chance of that, 0.4%, which is very low for this elderly population versus 2.2%. So really no concern there. So if you go to the next slide, and this is the way I'm going to do it throughout this talk, Dr. Durie's bottom line. So what's the bottom line here? Well, Revlimid plus low-dose dex is an excellent frontline therapy for transplant ineligible patients, and I would add to that as continuous therapy. So ongoing use of Revlimid low-dose dex is really an excellent therapy. It was well tolerated, had a very low risk of linkage to a second cancer of any sort, and really has, as Dr. Terry Facon, who presented these data for the IFM and for the M28 group, he said this really establishes a new standard of care. In the U.S., patients are fortunate that they can take this treatment right now and have been for several years. In France, patients cannot take this therapy, and so this will be extremely important because this will go to the European health authorities and will lead to the approval of this regimen as a new standard of care, as Terry Facon said, in France and throughout Europe. and also elsewhere in the world. Okay, so item number 2. So what was the other aspect of this? Well, in addition to just using Revlimid as a first therapy, one can also use Revlimid as a maintenance, so that after you've taken some treatment, you could use Revlimid later to maintain the response. And so there have been a number of studies on this, and so Revlimid Maintenance meta-analysis ASH 2013. So on this slide, there are a lot of small numbers here, but the result is basically a comparison or a combined analysis, actually, of 4 different studies. And what this shows is that if you give Revlimid after prior therapy, for example, in 2 of the studies, it's after autologous stem cell transplant. So if you have a transplant and have a response to that and then go on to Revlimid maintenance, the question is that helpful versus not taking the Revlimid as a maintenance? And so if you combine the results of these 4 studies, as was done by Dr. Singh from the Mayo Clinic team, you find that both the length of the remission and the overall survival was prolonged. So this was also a helpful approach to have ongoing Revlimid therapy. But I would have to say that at the ASH meeting, one of the most heated discussions was the presentation, the separate presentation of the results of one of these studies, which is the French study, the IFM 0502, which is the top one of the 4 in each of those 2 charts. So that for OS and PFS, the top number you'll see there is, for example, IFM 0502, and then if you look to the right, you'll see a bunch of black squares and diagonals and boxes, and you'll see that the top black box is off to the right, and it's right beside the red line. And what that means is that for this IFM trial, there was no overall survival benefit. But then you'll see all of the other boxes and diagonals are more over toward the left, which means that there was improved remission and survival. And so the big controversy at ASH when Dr. Michel et al. Presented his results separately was, well, why is that? Why does the French study not show survival benefit? Do we need to pay attention to that, or is that perhaps an outlier? Maybe the other results are telling us the story, and maybe there's an explanation why the French are not seeing survival benefit. And this was actually an extremely heated discussion at ASH, and I know some of the support group leaders were there and witnessed this, where a number of experts got up and actually disputed the interpretation of the IFM trial for various reasons. And I think that the best way to summarize this is that it is kind of an outlier right now where people are questioning, well, what's going on there? The trial included Revlimid, what's called consolidation, where all the patients got intensive Revlimid for 2 months after the transplant, and that might explain why there's no difference in benefit and overall survival. But there are a number of other, small points related to this trial that remain to be fully explained, I would say. But, next slide. So what is my takeaway about all of this? Well, Dr. Durie's bottom line on this is that Revlimid maintenance and or continuous therapy really looks good to me and deserves careful consideration as a very effective treatment strategy. And I would say that this is important both frontline, in addition to being after transplant, and as well as relapse. In previous ASH meetings, we've shown that continuing to stay on Revlimid at the relapse time point is also a helpful thing to do. So Revlimid continuous therapy is really an effective therapy, and obviously, like every therapy, you need to be cautious about monitoring toxicities and side effects, but really should be carefully considered as a positive thing to do. So, item number 3. And I apologize for some of these slides. They've got lots of numbers on them, and that's because I know that some of you love numbers and like to see what they show. But frontline therapy for elderly patients, this is a very, very important comparison between 2 drugs and 3 drugs. So obviously, if you take 3 drugs, there's going to be more side effects, more costs, more complicated to take 3 drugs versus 2 drugs. And so this was extremely interesting at ASH, where there were 2 trials conducted by the Italian group in this case, called GEMEMA, from the Torino group in the north of Italy. And in one study, they looked at Revlimid and Dex, that same Revlimid low-dose combination, versus a 3-drug combination of melphalan, prednisone, Revlimid, or Cytoxan, prednisone, and Revlimid. Quite a lot of patients, 659 patients, a lot of patients. And basically, the bottom line is you can see that the response and OS, overall survival, very, very similar. And so the 2-drug gave equal results, equivalent results, but obviously was less toxic, less expensive, less complicated. If you look at the bottom one with Velcade Dex, same story. Smaller number of patients, 152 patients, but VD versus MPV, CPV, melphalan, prednisone, Cytoxan, prednisone plus Velcade. Similar response, overall survival, but equal results with lesser toxicities. You can also see that if you look at overall survival at 2 years, it's a little bit over 80%. Actually, for the two-drug combo, 80% for both. So you can see that the 2 drugs, Revlimid and Dex and Velcade Dex, identical, really. I mean, it's very, very similar results, and you really don't need to use the 3 drugs. The 2 drugs seem to do a pretty good job. And this is especially important for the elderly population. So my takeaway, Dr. Durie's bottom line, Rev and Dex, 2-drug options, excellent. And really should be strongly considered versus the 3-drug or 4 drugs, whatever. And this is what should be strongly considered. There are several aspects to this. What it means is that you haven't used Cytoxan, you haven't used melphalan, so it does also include the aspect that you're saving drugs for later. I should also emphasize that this 2-drug approach is really part of a strategy of ongoing treatment to achieve chronic disease control. And so this will become important versus patients where you are doing a transplant, and as I'm going to show you in a second, you're maybe looking to push harder and achieve a much better response. Talked about that. So frontline therapy for transplant-eligible patients, the next slide. Frontline therapy for transplant-eligible patients. And so this is a slide which is looking at corphilson combinations. And so corphilson is the new proteasome inhibitor, what we call a proteasome inhibitor. So this is a new drug like Velcade, which was approved this past year in the relapse setting. So it's approved for use in actually relapse refractory myeloma. However, several teams have been looking at using corphilson combinations as the first therapy. And so I can tell you that people were pretty excited to see these results in the frontline patients. And so if we take the top study, corphilson, Revlimid, Dex, a very, very excellent combination. And this study was done by Dr. Ola Landgren's team at the NCI, 41 patients. Virtually all the patients responded, 97% response. Possibly even more important, you'll see in the top chart there, NCR, CR, SCR, 63%. So a majority of the patients are having very deep responses. So the patients are mostly responding with very deep responses. And you can see off to the right the overall survival at the time of the ASH meeting, all those patients were alive and doing well. Now, if you look at the bottom chart, corphilzumab combined with Cytoxan and Dex, CCD, this is from the Italian team, the Torino team. Again, very high response rate, very deep responses. I don't know why. For some reason, there were some patients who didn't do well in the study. So the survival was not 100% in this particular study. I think that this was a little bit of a coincidence where they had some patients with some special problems in this particular study, but a very, very well-tolerated regimen. And so next slide. So what is my bottom line for this item number 4? Well, clearly the corphilzumab combinations are working extremely well with very deep responses, high-level responses, and so really the follow-up question is, what do we expect with longer-term follow-up? As I'm going to show you in a moment, we also saw at ASH very good long-term results with Velcade, Revlimid and Dex, and Velcade, Cytoxan Dex, which is the CyBOR-D regimen. And so the question really is corphilzumab as part of these 3 drug combinations, is that better than the Velcade combinations? Are they equal, or should they be used more selectively? And this is really the $64,000 question right now. Should patients be getting the corphilzumab combinations versus the Velcade combinations? So let me take you to the Velcade data, and you could think about that for yourselves. And so if we look at the current standardized approach for frontline therapy for transplant-eligible patients, again, you will see 2 charts. In this case, you will have Velcade, Cytoxan Dex, and Velcade, Revlimid Dex. So very, very similar to what you just saw, but with corphilzumab. So what do we see with that? Well, you can see best overall response rates maybe just a little bit lower, and the progression-free survivals maybe a little bit lower, but you can see off to the right that there are 2 important things. The overall survival at 2 years is really very good, 84, 92%. But you can see, interestingly enough, that the Velcade Cytoxan Dex stacks up pretty well versus the Velcade Revlimid Dex. So this is quite important. Part of the concept is that if you save the Revlimid for later, that's an alternate therapy that can be saved for the future. So now if you look to see, well, what is the long-term follow-up with VCD, with this what we call CyBOR-D, Cytoxan Bortezomib Dex, CyBOR-D. You can see from this Mayo Clinic study, they looked at the long-term follow-up with CyBOR-D, and that's because they were the people who really extensively introduced this regimen. You can see that the overall survival out to 5 years was pretty impressive, 70%, 81% with this VCD regimen doing well at 5 years. So corphilzumab looks good, but actually the Velcade regimens are performing really quite well. And so if you go to the next slide, I just show you a little bit of follow-up information, and this just shows you the survival chart. So long-term survival with CyBOR-D, and this is from the Mayo Clinic team in Scottsdale. They show for the overall survival for all patients, and then with good risk. What that means is patients who do not have the bad risk chromosomes like 17p minus or the 1114. I'll talk about those risk features a little bit later. But if they have the good risk chromosomes, then 81% at 5 years. Really quite good, I would say. And so we need to wait and see what will be the outcome with, for example, CRD, corphilzumab Rev Dex, and CCD at that 5-year time point. If we go to the next slide, another set of data that was presented is if you actually calculate how much Velcade is given, it does make a difference. And so this was a study from Spain Dr. Maria V. Mateos from Salamanca in Spain, and she looked at data from the VISTA trial, and this is a trial which was Velcade with melphalan and prednisone, and she calculated that once you get to above this 39 milligrams per meter squared, so once you get above that maximum total dose, then patients do better. And so it's important because now with the availability of Velcade sub-Q, it means that patients can stay on the Velcade longer, and it is worthwhile because ongoing therapy does contribute to longer remissions and longer survival. And so it feeds in to this notion that to control myeloma, you do need to not stop too soon. That, you know, treat for 3 months, 6 months. It's important to have a more sustained control of the disease, chronic disease control with Revlimid, with Velcade, and also we have similar data with corphilson. This is an important aspect of treatment. So, next slide. Dr. Durie's bottom line, item number 5. Velcade combinations are also pretty good, and we need to see how they stack up versus corphilson over time. But the frontline results at 5 years look pretty good. Cumulative dosing is important, and it's pretty interesting that Cyborg-D, where you have the Velcade with Cytoxan, stacks up pretty well versus the Velcade with the Revlimid. So important to be aware of that. Okay. So, item number 6, long survival after auto-allo transplant. And so this is an interesting study. It's a study from Canada, and that's one of the interesting aspects. We don't see a lot of these pivotal trials coming out of Canada, but this was certainly an interesting and important observation where for a number of years they have been using consolidation with tandem transplant in the Montreal clinical trial here from the Hospital Maisonneuve Rosemont Montreal Hospital. 93 patients underwent an auto-transplant followed by a mini allotransplant from a matched family member donor. Now, the different thing about this particular study is, and it's not entirely clear why, but it may relate to the matching or the exact transplant rejection treatment that they used, is that there was quite a lot of GVHD, graft versus host disease, which is something which is absolutely not trivial, but they had quite a lot of graft versus host disease, which means that the graft, the transplanted cells were reacting against the patient and causing some skin and liver and bowel issues with extensive chronic GVHD in 85% of the patients. So they had a lot of graft versus host disease, which is not trivial. But this also means that the graft is very active and is shutting down the myeloma. And so they had 64% of their patients alive and doing well at 10 years. And so they were seeing some very sustained remissions in patients with this particular protocol. And so it's very interesting to see this, because what this means is that if you have an active immune response against the myeloma, this can be effective in shutting down the myeloma in a long-term fashion. And so this is an extremely important study to see this. We have known that this does happen for some patients, but this is an impressive individual study showing a high percentage. But if you go to the next slide, so what is my bottom line? Well, allotransplant definitely can provide long-term disease control, but the toxicities and the risks are definitely high. And so I think that I use this as a clue to prioritize maybe some better allo techniques or other T-cell therapies which we're seeing under development to try to have immune therapies that attack a myeloma. This tells us that these could have an important impact, and we need to perhaps prioritize those and look at them closely. Okay, so item number 7. So there were quite a lot of presentations, between 20 and 30 presentations on this topic. So this was an amazing aspect at ASH. All different kinds of studies looking at minimal residual disease. And this is because regimens like corphilson, Revlimid, and Dex are producing these really deep responses with just very low levels of disease left, minimal residual disease. And so this gives an opportunity to study these minimal cells and find out what are the features of those cells. And so 2 studies here from the team in Salamanca, presented by Dr. Bruno Paiva, who is a very active researcher in this area, a key investigator in the IMF Black Swan Research Initiative. He looked at 40 newly diagnosed patients and studied the cells that were left over after Velcade, melphalan-prednisone, or Rev-Dex, and he characterized the surface molecules, the adhesion molecules, the different coding features, CD11728, that were present on these resistant clones left behind. He also looked in the bottom paper, it was a separate presentation, at the genetic profile of these cells that are left behind. And so he found something that is quite interesting and quite important, is that we've learned that myeloma can have different subclones, but what he showed was that there is what is called clonal restriction or contraction. If you look after therapy, the number of clones which is left behind is less. And so maybe you start off with 5, 6, 7, 8 clones. You might end up maybe just with 1 clone that's resistant. And this is a lot easier to study and to think about how to eliminate. Clonal restriction occurs in 78% of the samples from the patients that he tested. So next slide. A big question at ASH is, if you're going to look at MRD, there are 2 tests for that. One of which is called flow, where you take the bone marrow cells or blood cells and run them through a flow machine where the cells are individually analyzed to see if they're myeloma or normal cells. Or you can take the bone marrow and do something called deep sequencing, where you study the DNA and see if you can find any DNA sequences from the myeloma, or if the DNA is normal. So those are 2 different approaches. One where you run the cells through a flow machine like doing a blood count, the other where you study at the DNA level. And so, again, this is from a Spanish team, and they had 133 patients that they studied with the deep sequencing, and they compared it with the flow. The deep sequencing technique is called Lymphocyte from the Sequenta company, which is based in San Francisco, and they look at something called VDJ. And what that means is that the genes which code for the myeloma protein have variable, diverse, and joining regions. And those get scrambled around to give the specificity for the myeloma protein. And so each one is unique. And so if you look at this VDJ, the variable, diverse, and joining region sequence, that is a complete key to the sequence which is linked to the myeloma. So you can exactly identify the myeloma clone. This was possible in 91% of the patients, so that this is not something that is possible for every patient. You need to have a baseline sample, and then you need to identify what's called a dominant clone to figure out your testing. And so that's a downside to this. 109 out of 133 had paired samples to study flow and DNA. So again, it's difficult to do these kind of comparisons. The bottom line was that you get different results with these different techniques. The DNA and the flow were comparable in terms of positive 80% of the time, but on the negative side, there was quite a bit of discrepancy. And so clearly, we need to continue to look at this and get an idea about what's best and come up with the best test. And the IMF, through its Black Swan Research Initiative, is very, very committed to coming up with the best testing protocol. And so if you go to the next slide, which says MRD and outcomes, this tells you the reason that we are interested in this, because there's no doubt, and you can see it on this chart, all of the red lines here are above the black lines. And so the red line means that you ran the DNA test and it was negative. So if the test is negative, patients definitely do better. And so we need to have a sense of how sensitive is that. So if the MRD test is negative, the key question is, do we then have the confidence to say that, well, we've done a complete job and we can stop the treatment, or do we need to see that this is sustained, or do we need to be secure that this is a sensitive enough test to be making those kinds of decisions? If you go to the next slide, there's another group, an Italian group, that was looking at the long-term results of molecular response. You don't really need to look at too many of the numbers here. Some of you may be interested to study these slides later. But again, the main thing here is that if there is MRD 0, patients do better. Even if the patients relapse, and this is an important point to keep in mind, is that if you achieve MRD 0, then at the very least the response is going to last longer, in this case with at least a 9-month lag time. And so we know that patients are definitely going to do better if they get to this low level of disease and more deep response. Next slide. Now, we're also looking at other predictors that would tell us how patients are doing, and it was pretty interesting to see that a new test, Heavy Light, which studies the heavy chain linked through the light chain with the myeloma protein, the new Heavy Light test, which is for IgG and IgA, you can monitor the amount of the myeloma protein at a very low level. And Ola's team at the NCI, they found something extremely interesting, which is in the red box. And it's a small number of patients, 38 patients with myeloma 12 with smoldering myeloma. They found that if the Heavy Light test corrects towards normal very quickly within 2 cycles, then those patients move on to get to MRD 0. And so this tells us that a simple test like the Heavy Light test maybe is sufficient to tell us that patients are going to do extremely well. So there's quite a bit of excitement about that, and we need a lot more follow-up. These are extremely small numbers, but maybe Heavy Light could be an important test to use in this fashion. The next slide shows MRD with CRD in newly diagnosed patients. And so I already showed you that CRD was really good up front. And so this just shows you, if you look at MRD, the minimal residual disease, I've put a red circle around it off to the right there. This is a small number of patients. You can see using the flow method, flow cytometry, 17 out of 17 patients with this regimen achieved MRD 0. And so this is amazing that this regimen does seem to be giving us deeper responses with this MRD testing than we have seen in the past. And so this is one of the things that raises the question of CRD versus VRD. And There is a trial going on right now which is comparing corphilson and Velcade in a head-to-head fashion called the Endeavor trial, and so we're all going to be waiting to see the results of that. Another aspect of minimal residual disease is that you can look at all of these molecular and flow tests, but maybe there is a spot of myeloma somewhere, and so MRD and imaging is also extremely important. And so there was a very, very interesting study from Bologna in Italy, and what they showed was that if you take patients who appear to have had a complete remission by standard methods, that excludes MRD, not looking at MRD for now, but just with protein and other techniques, bone marrow and the like, 29% of patients who appear to be in CR actually have a positive PET scan. And so what that means is that we need to also consider the PET scanning methodology. And so what they also showed is that if you have a CR and your PET scan is negative, then the outcome is better. Then the overall survival was 90% at 6 years for patients who had a CR and the PET scan negative. So this tells us that we need to also include imaging information when we are thinking about assessment of minimal residual disease. So that was MRD and imaging ASH 2013. I have a second slide which is called other imaging, the next slide, other imaging data at ASH, and that just has another couple of slides about PET and also extramedullary disease. And this basically shows that if you have a positive PET-CT scan, you're more likely to have extramedullary disease, where there's disease outside of the bone marrow. So if you're finding lesions in this kind of a situation, then they might not all be in the bone marrow. They could be in a soft tissue somewhere. And this seems to be occurring more since we've started to use the novel agents. And so, again, Dr. Paiva from Salamanca, in that second study there, he showed that with novel agents, 14% versus 6%. So it's occurring more frequently since we started to use the novel agents. But again, you have to keep in mind that patients are doing better with novel agents and they're living longer, and so ultimately then they would be more likely to have this happen. If you go to the next slide, which is the final slide in this segment, this was an analysis from the Mayo Clinic, extramedullary myeloma, ASH 2013. And what this shows is this is a large number of patients that the Mayo Clinic experienced, over 1,000 patients. And so what they're trying to get a handle on is, okay, we're talking about extramedullary plasmacytomas, what we call EMP, and that this is at a pretty low level, 2.5% at diagnosis, 6.5% at relapse. And so although this is important and we tend to emphasize it and talk about it when it happens, fortunately it's still occurring at a relatively low rate, even when you look at it in a cumulative risk fashion and look at the outcome. Obviously, over on the right at the bottom with the red chart there, you'll see that red, no extramedullary, does better than blue, which does have extramedullary. So that if you're starting to develop those lesions outside the bone marrow, that's obviously not so good. But fortunately, still occurring at a rather low level. So what's my bottom line for this? So clearly, MRD measurement is key in 2014 and moving forward to assess how well the treatment is working, and also to use as a test to try to achieve cure for some patients. But we also need to look at flow, DNA, and imaging as we try to assess if a patient is truly in remission, and certainly if they have achieved a cure. All right, so we're moving to item number 8, new therapies. I've listed what are the top 8 new therapies that were presented at ASH. I don't really have time to go through all all of these abstracts, you can see that I've listed the 8 therapies, but you can see there were multiple abstracts for some of these different therapies. I would say that they are somewhat in order of interest and priority. Clearly, the results with the new monoclonal antibodies, anti-CD38, now not entirely new. We had results from ASH last year, daratumumab. The interest in this is conveyed by the fact that there are 3 different pharmaceutical companies that have slightly different anti-CD38 monoclonal antibodies. So there's one which is a Genmab company, which is daratumumab, and then there's the Sanofi company, which has the SAR 650984. So I'm sure that's going to get a name soon. But these target the surface molecules, the CD38 molecules on the surface of myeloma cells, and myeloma cells are rich in these molecules. And so the key thing is, are these antibodies strong enough? They certainly bind to the CD38. So these antibodies bind to the CD38, but they also have to have the ability to cause damage to the membrane of the cell and such that the myeloma cell is killed when the antibody attacks it. So yes, we have a very good target, but you need to have an antibody which is potent, and that's the difference between these different antibodies. They have different binding and killing potential. So I'll show you some results in just a second. For the others, MLN 97708, this is the Millennium. It's kind of like an oral Velcade, a lot of interest in that. And these other drugs, I'll show you little bits of data about each of these different agents. And so if we go to the next slide, the top abstract, I would say, was the discussion of the SAR, the Sanofi anti-CD38. So this is anti-CD38 ASH 2013, SAR phase 1, 27 myeloma patients with good safety, but they were seeing responses. I'll show you in a minute, not just PRs, but the full results were showing VGPRs. So really very active as a direct antibody approach to treatment, so really quite exciting. We had some follow-up results with daratumumab combined with Revlimid and Dex, and when you combine, you were seeing even higher levels of response, greater than 50% VGPR when you combine daratumumab with Revlimid and Dex. And then using some mouse models, we heard data that daratumumab can be synergistic with Velcade and Revlimid. And so we look to having a direct activity, but also very, very good chance of strong interaction with both the Velcade type of drugs and the Revlimid type of drugs. This next chart, SAR 650984, phase 1 dose escalation, you can see it's got different colors, yellow, blue, red, and green. This is the different doses of the drugs, and so they're testing to see the different doses. But you can see the red, the 10 milligram, which is a higher dose, you can see there are more lines going downwards toward the bottom there. So very high level of response with some of the patients. 2-3 patients were getting very high level of response with anti-CD38 when you gave that little bit higher dose of the medication. So very, very encouraging data presented by Dr. Tom Martin. So then, what other things did we hear about in the new drug area? Well, these are not new drugs, but pomalidomide with Velcade, they're rather new, certainly as combinations are new. There was a Mayo study and a Dana-Farber study, both showing very good results combining those in relapse patients. they're not fully refractory, but patients who've gone through significant prior therapy, you can see very high response rates, 83 and 75% response rates. So combining pomalidomide with Velcade, very good results. Go to the next slide, some other novel agents. These are three, they're much earlier, and these are just names that you might want to keep an eye on. Selinexor, KPT-330, Array 520, they have different detailed mechanisms of action. The ACY, this is from the Acetylon company. This is what's called a selective HiDAC inhibitor. We've had two new drugs like this, Vorinostat and Panobinostat, where we have much more mature data. It's suggested that this selective HiDAC inhibitor could be even better, but the studies are very early with these three novel agents. So basically, something to watch out for next year, although trials are available this year. Then I would say that now this is a study in which I'm involved. My group did this particular trial next, the corphilson, pomalidomide, and Dex in refractory myeloma, patients refractory to Revlimid and Velcade. And so this was presented by my colleague Jayton Shah from MD Anderson, and we were really impressed to see that the overall response rate with this combination in patients who are refractory to Revlimid and Velcade was 70%, including mixed responses 83%. So a very, very high response rate in patients who'd basically gone through everything. And if we looked at the outcome, we are seeing extremely good survival both in high and standard risk. So survival and risk status, both the remissions and the overall survival, very, very good. And if you look at the survival chart, you'll see that the survival, we have excellent survival at 2 years. And so these are patients who were really under really severe threat for their survival, gone through pretty much every drug that we have, and we are seeing excellent survival at 1 to 2 years at this point. So really quite impressive results, even in the face of 17p minus. So bottom line, Dr. Durie's bottom line, item number 8, anti-CD38, very good. Combinations of recently approved new agents, also remarkably effective. So very encouraging both for new and new combinations. So let's just keep going through so we can finish up and have time for questions. High-risk assessment, ASH 2013. Really, this is a work in progress, is the summary here. It was interesting to see if you have a mixture of good risk and bad risk, how does that pan out? So coexistent hyperdiploidy, which is good, and high-risk fish, which is bad. So what happens if you got both? Well, the high risk really predominates. If you have the high risk along with the good risk, then the high risk is the one which really dominates. And so you can see if you have that high risk, even if you have the good risk with it, the overall survival was 35 months versus 60 months, 60.9 months. Then at the bottom, you can see that if you have too bad, then that makes it even worse. And so if you have 17p and something that could make it worse, it does. So that we're moving beyond the simple fish classification, and it's kind of annoying that it's become somewhat of a moving target where we're continuing to classify, well, what is high risk, and it depends on which molecular test or fish test that we use and also which treatment that we use. And so, bottom line for number 9, risk assessment is still a work in progress. And so, yes, we need to pay attention to it, but it's very much influenced by the treatment that we use. I just showed you that for high risk, 17p minus, we saw excellent results with corphilson, pomalidomide, and Dex. So we need to be still looking for new and simpler markers that will guide us to really identify risk that would maybe help select therapy or identify which is which is the best therapy in certain circumstances. So the final area, which is kind of new and interesting, is predisposition to MGUS and myeloma. So why do some people get MGUS and myeloma versus others who don't? And then this was a study quite complicated in mice. This study was a collaboration between the Mayo Clinic and Washington University. They had these special Cal-Ridge mice, and they found that if one particular gene was lost, this SAMSN1, then the mice would get myeloma. The interesting thing is that what this gene does is it makes both the B cells and plasma cells, as well as macrophages, so other cells in the bone marrow active, so not just myeloma cells. And so this gives the impression that the susceptibility to myeloma is linked to kind of a hyperactivity, not just in the myeloma cells, but maybe other immune and other cells in the marrow. So it gives an idea of a broader susceptibility factor. Another especially fascinating finding was that if you look at chronic infection in patients with MGUS, it was discovered that if you study the myeloma protein, the monoclonal protein, and this is a study from the French group in Nantes, they found that 22.7% of the patients, the myeloma protein actually reacted against a particular type of infection, either hepatitis, Epstein-Barr virus, or H. pylori, which is an infection in the stomach which can cause ulcers. And so this raises the possibility that infection actually could be a trigger factor for myeloma, because the monoclonal protein is actually reactive against infection. And so this opens up a whole area of research which I'm going to suggest that we will see a lot more about that. So we're starting to understand Dr. Durie's bottom line, number 10. We're starting to understand what causes myeloma, why some people may be getting it, and potentially, if it's linked to infection and some of these things, maybe some interventions that could lead to prevention strategies. And so, summary takeaway points. I've already pretty much summarized this, but the 10 items. Revlimid is good. Revlimid maintenance is also good. So Revlimid continuous therapy looks like it's good. 2 drugs could be enough. Corphilson is really looking pretty excellent. We need more data to see how corphilson versus Velcade will stack up. We do know that Velcade is very important, and that especially with the sub-Q Velcade and the CYBOR-D results at 5 years, this is really well tolerated and producing very good results. So it's going to take some time to see the balance between these two strategies. Many allo can provide benefit at a cost. MRD testing, increasingly important. Anti-CD38, I think I'm very keen to see the results this coming year with this and how we start using this in therapy. The anti-CD38 daratumumab has received a fast track or breakthrough designation at the FDA, so we are hoping that that would possibly be one of the next drugs to be approved. We're trying to still figure out some details about high risk, and it's definitely interesting to see number 10, some predisposing factors identified related to MGUS and myeloma. So hopefully this has given you an overview of what happened at ASH, and a lot more went on, a lot of other different debates and conferences, but these are some takeaway points. So thank you for your attention. I have my balanced rocks as my last slide with the little black swan sitting there. There's always a balance between efficacy and toxicity. However, with the black swan coming into the picture, we have the idea that that balance could be between trying to push to achieve a cure and what it takes to accomplish that. So thank you again, and we will have time for questions, and let's go to that.
And at this time, if you'd like to ask a question, press star followed by the number 1 on your telephone keypad. Again, that was star followed by the number 1. And your first question comes from the line of Gerald Orris.
Yes, Dr. Durie, I have a sort of an outlier complex question. I'll make it short as I can. I'm a stage 3A, treated with autologous transplant about 2.5 years ago, followed by Revlimid, which I stayed on for about 15 months.
15 minutes.
15 minutes, I wish, until I developed toxicity.
Okay.
Interestingly, looking at my lungs prior to my transplant, I had evidence of sarcoidosis.
Oh.
Now, sarcoidosis has been very, very rapid in its progression, not only my lungs, but also my myocardium.
Oh.
So 6 weeks ago, I was started on prednisone, and we're worried about the dose and what it's going to do to me because of my osteopenia. And now I have been being switched to methotrexate.
Okay.
My question is multiple. One, relationship between my disease, multiple myeloma, and sarcoidosis. And 2, relationship between the effect of prednisone and or methotrexate on my disease, multiple myeloma.
Right. So there are some complex aspects to this which I'll touch on, but please feel free to call in to the hotline afterwards, and we can perhaps discuss some of the details offline. But a couple of things. One is that sarcoidosis is an abnormal immune response. It's thought to maybe, you probably heard this, to a TB type of infection or some granulomatous process. So it's an abnormal immune response, kind of a hyper-immune response, and that's why the treatment with prednisone to shut down the inflammation. It is something that can be linked to myeloma. You're not the first patient with myeloma I've heard of with sarcoidosis, that's for sure. I think that fortunately the prednisone is obviously a pretty good treatment for myeloma. The methotrexate we will need to be cautious about, although there are some old data that maybe even it might have some anti-myeloma effects. I would be concerned, however, in your case about the Revlimid, and I would encourage you, we should, when we talk, we should look at the time frame and see if that was in any way linked to the sarcoidosis flaring, because that would be very important to know, because Revlimid is an immune modulator.
So this is Susie Novus. I just want to chime in here. I think it's obviously everybody has questions about their own personal situation, and unfortunately we just don't have time to really address those types of questions. So if everyone could kind of keep your question as general as possible so that it would be of interest to the other people who are on the call. If you want a private consult, just call the IMF and we'll see what we can do to arrange one.
Yeah, if you've got more complicated questions, and if we don't get to you on this call, please feel free to call in and we can get them offline. So thank you, and hopefully that'll start to answer some of your questions, okay?
Thank you very much.
Your next question comes from the line of Gordon Bredauer.
Yes. Please go ahead, Gordon.
Yeah, I guess I didn't have any question.
All right.
Well, nice chatting with you, Gordon.
Well,
yeah, I didn't push the button or anything.
All right.
That was fast.
Yeah.
Your next question comes from the line of Susan Solstein.
Okay, go ahead, Susan.
Hi. I also don't have a question.
It's okay.
Wow. Okay, this is getting
We'll be done in no time.
This is excellent. Okay.
But it's too personal, so I can call the hotline.
That's fine. No, please feel free to do that, and we can discuss offline. No problem.
Okay. Thank you, Dr. Durie.
Your next question comes from the line of William Bell.
Maybe not.
Maybe not.
Your next question comes from the line of Elena Worth.
All right.
Hello. It was a very interesting talk, and really, I hate to say the question I have was more of a personal disease. I've been surviving for 12 and a half years and with a great quality of life, but I too will call the hotline.
Great. They'll be pleased to talk to you.
Okay, no problem.
Your next question comes from the line of Carmen.
Hi, Robin and Dr. Durie. I want to know if there are places or studies where Velcade is administered only by itself as maintenance therapy and what the success rates are. And I also understand that there is a study that I think Dr. Anderson is conducting
yes.
on Velcade and combining Velcade versus stem cell transplants. So
yes,
can you
yes. I can talk about those two things, yes. So Velcade can definitely be used as a maintenance, and so this is a good question. So with using the sub-Q Velcade, and if a patient's responded well with Velcade, what we can consider now, which is relatively simple, is to give the Velcade by sub-Q injection twice a month. And we do have data on the benefit of this from a large study that was conducted by the Holborn group, a group in Holland, in the Netherlands, in Europe, and they showed that this type of a maintenance with the twice-a-month Velcade did produce longer remissions and survival. And so it was kind of a complex study, and so people are looking for other studies to confirm this, but very encouraging that Velcade maintenance is worthwhile and helpful.
Doctor, you were talking about total Velcade. Did they address that issue also in that study in Holland?
Yes, so that it was clear that staying on the Velcade and getting that higher cumulative dose had a positive impact, yes. And so the study that Dr. Anderson is conducting is the one with the Dana-Farber and the IFM, a combined study, where they're looking to see if you have Velcade Rev-Dex and then maintenance, in that case with Revlimid, what is the impact of having a transplant or not? And so that's looking at, a different kind of a factor. What is if you've had a fantastic response with Velcade Rev-Dex, what is the added benefit of having an auto stem cell transplant? The results of that will be a year or two in coming for sure. That's just an ongoing study.
How do I get hold of that study? HO what, doctor? Do I call the hotline? The Holland study?
Yes, call the hotline, and we'd be glad to give you the protocol details so that you understand that. Yeah, we have all of that, yes.
Okay, and I want to tell everybody that those workshops that you do are wonderful, so try to go to them. I have run to two of them in my 2.5 years of having to deal with this illness, and they have helped me a lot. Thank you so much.
Oh, thank you for that. We appreciate that kind of feedback. Thank you so much. Okay.
Your next question comes from the line of Sally Scott.
Yes, Sally. Okay.
My question is, I have problems with the neuropathy in my feet, and I'm taking what is it? Jenna, how you pronounce it? I can't think of how you pronounce it. Jenna Penny. And it doesn't seem to, I just got the dosage increased last week to 300 milligrams, but I can't tell whether it's really helping or not. Is there anything else that could be used to help that I could do on my own or something to help me with that?
Yes. So, again, I would encourage you to call the hotline because we do have quite a number of things that you could look at to try to help. But we do have these drugs which are basically for pain. There's one called Cymbalta. There's also another one called Neurontin, gabapentin. I mean, there's a class of drugs which deal with the pain, which can be helpful, but we have a number of things that we can do, supplements that could be considered. And so, again, for any of you on the line, you can call the hotline. We can also send you, we have kind of like a recipe of things which are, for example, recommended by the Dana-Farber team that they came up with, and also everything from massage to acupuncture to a variety of things that can often be quite helpful to help with the neuropathy, which I'm sure you realize can be very difficult, and hopefully it can improve over time. But we can help you. Okay, so call the hotline and get more detail. Okay.
All right. Thank you much.
You have a question from the line of Brian Peart.
All right.
I did nothing, I swear.
Okay.
Well, call the hotline anyway.
Well, it's
Sorry,
great to hear
thank
your
you.
voice, Brian.
Yeah, no.
Your next question comes from the line of Joanne Lorenzo.
Joanne?
I don't know. I don't know.
Maybe another caller, operator.
Maybe try one or two other callers. We'll probably take maybe one or two more questions here because we're getting towards the end of our time. But any other calls that from someone who actually pressed the button?
You have a question from the line of Yilak Durie.
Oh, hi.
Oh.
Hi.
Hello.
Hi, Dr. Durie. Thank you for speaking English and not doctor this evening. I think you articulated one of the things we have seen more this year's ASH than previous is the somewhat subtle use of Cytoxan in combination with the novel agents.
Yeah.
I think this is really interesting as it will help contain cost, extend drug availability outside of the U.S., and is really convenient for younger patients like me who like their doctor but don't want to visit them as often. So my specific question is, what's your either retrospective observation or clinical trial results of Cytoxans long-term use compared to other novel oral agents as it relates to tolerability and myelosuppression?
Right. So you're exactly right, and I did show some of the data, the results with the Cyborg-D, Velcade Cytoxan Index. I think very impressive, and I think that there has been some anxiety about possibly the longer term, the blood count effects with the Cytoxan, but actually, with our experience with the Cyborg-D, you definitely do need to be cautious about dose adjustment and maybe giving some rest periods with the Cytoxan. With Cytoxan, it can cause anemia in addition to some reduction in white and platelets. And so with monitoring, you can have long-term use for years, actually. And for patients who are using the Cyborg-D regimen as a backup regimen, so in the relapse setting, we now also prefer patients to be staying on the regimen. So it's important to dose reduce, make the adjustments of Velcade or Revlimid and the Cytoxan for blood counts, also neuropathy or whatever, but then to try to sustain the treatment at a lower dose level to get the most out of the therapy. You also saw the benefit of the cumulative dose of the Velcade. So I think that we're less concerned about Cytoxan in terms of permanent effects. We see the rebound of the blood counts if you give some rest period or dose reduction. We're also seeing the shift away from IV Cytoxan to the Cytoxan by mouth, which is also something which is easier and well tolerated. Yeah, so thanks for that question. I think a very important point.
Thank you.
All right. we'll probably have one more question, and then Susie, we have a poll and some wrap-up here.
Yep.
So one more, perhaps.
And your final question comes from the line of John Bianco.
Thanks again for the presentation, and I'll also call the hotline, but I do have a question.
Yes.
After a third relapse in July of this year, after 13 years, I added 20 milligrams of Dex to 25 milligrams of Revlimid, and got a good response out of that.
Good.
3 months later, we reduced the Dex from 20 milligrams to 12 milligrams.
Right.
And after 2 months of that, my numbers jumped 20%, IgG, M-spike, and kappa.
Okay.
So we immediately went back to 20 milligrams of Dex, and I'm in that cycle right now. But have you seen that kind of change with just going from 20 to 12?
Yes. It seems so simple, and these numbers seem so small, but actually there can be a delicate balance, and we need to what we call titrate the dose that works best for each patient. And so we need to stay alert, but the good news is that the chances are excellent that going back up to the 20 will be sufficient to recontrol your myeloma. And so it's important to monitor closely and then kind of find out what is the critical dose for you and for every patient. It can be 16 milligrams or 20 milligrams or maybe 24 milligrams, and then get back onto that, and then reduce again the dose slowly. But if you discover this need for the Dex, then you need to find a way to stay on that. Another thing just for you to keep in mind is that if we see that there's a need for something in addition to the Revlimid alone, there are many opportunities to add in other things. For example, we will add in Biaxin, which is an antibiotic, part of what we call the BIRD regimen. You can add in Cytoxin. And so if you do that, if the Dex is a problem, the side effects of the Dex are a problem, you can add in something else which would allow you to keep at a lower dose of the Dex but sustain the response of the combination. So this is an important part of monitoring and juggling. This is the art and the science of doing the best for myeloma patients.
Well, I'm using this as a stepping stone to really the next major treatment to try to get a deep response, perhaps going back onto VRD, which I did in 2009 with a very good result.
Okay, well, happy to touch on your personal situation in more detail to see what's best, okay?
Thank you.
All right. Okay, so I'll turn it back to Karen, I guess, who I think there is a very quick poll of 5 questions, and then Susie has a few comments that she wants to make at the end here. So, Karen, if you would like to take us through there's 5 polling questions. Sorry about this, folks, but just quick questions for you before we wrap up.
So first of all, I want to thank Brian. Tonight's teleconference was really wonderful, and I'm sure that everyone on the call really appreciated your update, and most of you will have a lot of follow-up questions. So as Brian kept repeating, we really do suggest that you call the hotline. We've got 4 wonderful hotline coordinators, and they'll be able to help you. Just in case you don't know the toll-free number, it's 800-452-2873. A really fantastic way to stay abreast of all the new data and how it impacts your treatment options is to attend one of our patient and family seminars. So the first one of the year will be held in Boca Raton, Florida on February 28th through March 1st. And what a great way to kick off a Myeloma Awareness Month as well. So if you want to register, just call us here at the IMF again at 800-452-2873, and I'm sure you'll be glad you did. I want to thank our sponsors, Celgene and Millennium, for their support. And before I close, I want to thank our wonderful support group team here at the IMF, Robin, Kelly, Nancy, Sue, and Ann, who work with many groups all across the country, helping you in very, very positive ways. So that's it. Thanks and I hope you have a wonderful evening, and I hope to see you soon, especially in Boca's coming up soon. Okay, thanks so much, everyone. Good night.
Thank you. Good night, everyone.
And this does conclude today's teleconference. You may now disconnect. Presenters, please hold.